Welcome, everyone. I'm Robert Klitzman. I direct the Master's Bioethics program, and we're deeply honored to have David Blumenthal with us this evening. Dr. Blumenthal is president of the Commonwealth Fund, which is, I think, really one of the nation's, if not the nation's, leading health policy foundation. Before that, he was a Sam Thier Professor of Medicine at Harvard, and he has been the Chief Information and Innovation Officer at Partners Healthcare System in Boston. He also served as the National Coordinator for Health Information Technology and helped to build a nationwide, as I understand it, health IT system. He was earlier in his career practicing primary care physician. He was director of the Institute for Health Policy at Harvard, a professor of health policy and medicine. In my mind, stands out. Those of you taking my course know that we read his work on conflicts of interest. I really think he was seminal in putting conflicts of interest on the forefront of issues that need to be addressed a number of years ago when they weren't. He is the author of more than 250 books and scholarly publications, most recently Heart of Power, Health and Politics in the Oval Office. He is on the editorial board of the New England Journal of Medicine. He's a member of the Institute of Medicine. He's received many, many honors, which I won't go into now. It'll be time for him to speak. I'm just going to say I'm going to pass around a sign-up sheet if people could sign in so we can make sure that we are able to contact you about our future events and be grateful. And without further ado,
Thank you. Thank you, Bob. Well, pleasure to be here. I'm going to sit. This is a very informal, small group, so I'd rather do that than prance around in front of you or stand at a podium. I'm going to talk about the mission of the Commonwealth Fund, but provide a perspective on the mission. The mission of the Commonwealth Fund is to create a high-performing health system, and it's that mission that attracted me to the fund when, as I worked for it and with it as an academic, but then also when I had the chance to come to New York and work here full-time. So what I'm specifically going to talk about is some of the challenges that our healthcare system faces right now, some of which may be familiar to you, but I'll try to just remind you of them so that you have them in sight as we go forward. Then I'm going to talk about some of the alternative pathways for managing those challenges, some of the next steps that have become available to us or have been proposed. And then because in many audiences where I speak, people think that I spend all my time on IT, I'll give you a little bit of an update on information technology, just in case some of you expected that of me. Maybe you didn't, in which case I can pass it by. We have a broken healthcare system. You all probably are well familiar with that. We have problems of cost, quality, and access to care. We still have more than 50 million uninsured Americans, comparable to the population of many European nations, and we don't get good value for what we spend, and we spend an incredible amount. I'll say more about that in just a moment. So uninsurance, 30% of working age adults are uninsured. Now and during any given year, that number has been going up steadily over time. As people talk about the problems of the rollout of the Affordable Care Act, we often forget how dysfunctional the system that preceded the Affordable Care Act was and still is for many Americans. And the reason why the numbers of uninsured are growing is because the insurance industry is not able anymore, and the healthcare system is not able anymore to provide stable insurance for the American public. If you look not just at those who lack any insurance at all during the previous year, either all year or at some part of it, but also look at the adequacy of insurance, what you find is that by some definitions, another 50 million 55 million Americans, 30 million Americans are underinsured. So the total of the uninsured and underinsured come to about 85 million, about a quarter of the American population. By underinsured, the Commonwealth Fund, which collected this data and collects it on a regular basis, means that people spend more than 10% of their income on medical expenses in any given year, or if their income is less than 200% of poverty, spend more than 5% of their income on medical expenses. We're releasing tomorrow the results of a regular survey we do of 11 different countries that looks at, among other things, how much people report spending out of pocket on healthcare, and how much trouble they have with the insurance system, and whether they have barriers to access that are financial in nature. And the United States stands out on those measures as being having many more frequent problems. Actually, and even our insured have more problems in that domain, in those financial domains, than populations of the 11 other countries that we survey. One of the reasons why insurance is becoming, or uninsurance is becoming more common, is because healthcare expenses are going up much faster than people's wages. So these charts track rates of increases in premiums for healthcare and rates of increases in workers' earnings in the United States, as well as overall inflation. And what you see is that this product, insurance, private insurance, is on a trajectory to being not only unaffordable, but beyond any conceivable reach of most Americans, most working Americans. And if you want to know why the insurance industry has been so quiet about the trouble with the Affordable Care Act, all you have to do is look at this graph to realize that they understand that they don't have a future for their product unless the government subsidizes it. That's why they have been supportive of the Affordable Care Act and remain very quietly working with the current administration to make it deployed and work. Now, we are unfortunately not healthier, despite the fact that we spend a lot of money. We have poorer health outcomes than many other Western countries. Even if you control for demographic factors, we have poorer health outcomes. So for given levels of education, for given levels of income, our health is less good than is true of England or France or the Scandinavian countries, Germany, Austria, most Western industrialized countries. There are interesting and unfortunate geographic disparities within the United States. Though overall the healthcare system doesn't perform well, parts of it do perform reasonably well in certain geographic areas. So the yellow areas are areas where the health system performs relatively well. The blue areas are areas where they perform poorly. Our national performance, and this is according to about 60 indicators of population health, efficiency of care, quality of care, and utilization of care, cost of care. If the blue areas were not part of the United States, we would actually do quite well by international standards. But we are one country with many varied locales. This data, by the way, is local data about health system performance. So what you see is that in the middle of Texas, there are high-performing areas. They tend to locate around Austin. In Florida, there are some high-performing areas. In North Carolina, there are some high-performing areas. But the large block of deep blue are areas that are persistently less well-performing on health or health care, health services or health care results than the rest of the United States. And if you look at low-income populations, you see that the same pattern replicated as you would expect. As a matter of fact, one of the startling things that this data which came from a scorecard that we published earlier this year. One of the startling things that this revealed is that if you are a low-income person in one of the lighter colored areas, especially so the middle and the north central part of the country or the northeastern part of the country, you do better in terms of your health and health care than if you're a high-income person in one of the areas that is dark blue. So the differences are so dramatic that income is no protection against bad health care or lower health or lesser health, and having low income is not a barrier to getting good care. This is, I think, an untold story about the United States, that there are these regional differences that are quite dramatic in nature. Now, if the healthcare cost Olympic Games were played out in the United States somewhere, we would take gold, silver, and bronze. We are way out ahead of all the competing countries around the world, and the gap is growing larger. So we are winning this cost competition hands down. That's not new to you, I'm sure. So this combination of issues, and particularly the cost issue, because what has galvanized the attention of policymakers, though you wouldn't know it from listening to the current debates, but what really has galvanized policymakers is the cost of care. That is what most troubles the American people. That is what most troubles our federal leaders. That is what underlies the federal deficit. It's what, when people talk about entitlement reform, they really are talking about reforming Medicare and Medicaid because of their extraordinary costs. And it leads you to the conclusion that in this underperforming health system that we live in and depend upon, we have really some major choices to make. That the graphic about the affordability of insurance is a graphic about the affordability of care generally. And though subsidies from the federal government can help in the very short term, the federal government can't afford to subsidize insurance whose cost is escalating at the rate that it has been escalating. So in some sense, getting more efficient in our healthcare system is a precondition to assuring equity in our healthcare system. So we have to decide what route we're going to take to get there, and there are two broad choices. One of them is to transform our healthcare system to make it higher performing, get more from every dollar we spend. And this is perhaps where ethics becomes relevant. And the other choice is, to all intents and purposes, rationing of care. So you can ration care in lots of ways, as I'm sure you've discussed. You can raise the price of care and force people to pay more, which will price some people out of the market, and therefore they won't get care. You can also change the eligibility for public programs, either on the basis of income or age. You can cut the benefits of health insurance or raise the price of health insurance, or you can reduce what you pay providers to the extent that providers may in the end stop seeing patients because it's not feasible to sustain the cost of doing business. And that's basically what's happened in many Medicaid programs around the United States. It's not happened yet in Medicare, though people are fearful that it will. So fundamental delivery system reform versus various kinds of reduction of services are kind of the choice, the global choice that we face. And most people would prefer if we could find a way to get more out of every dollar we spent to do that. Now, it's not easy to do that. And we've been struggling to try to do that for a long time. and we haven't made much progress. So the question is, how do we think about this going forward? How do we think about getting more out of our healthcare system? What is fundamental delivery system reform? And this is really what a lot of the work of the Commonwealth Fund is about. And when you're thinking about something like this, you have to start somewhere. We have to have some kind of conceptual framework. And this is a cartoon of a conceptual framework, but I find it useful for communicating. It's actually based on, very loosely, on work that Steve Shortell led in Crossing the Quality Chasm, the Institute of Medicine report from the first decade of this century. And Steve had a much more elegant and complete chart. I couldn't remember it all, so I made it very simple. And what this postulates is that there are two kinds of systems that work together and separately to influence performance: microsystems and macrosystems. And what do I mean by microsystems and macrosystems? Well, microsystems are the place where, in my clinical life, I spent my time. Any of you around this table who are clinicians or work in healthcare provider organizations will recognize microsystems as things like emergency rooms, intensive care units, operating rooms, admitting departments, places that clean operating room equipment or produce the food for patients. They're places where care and services are delivered, where the rubber hits the road, if you will, and people get care and people provide care. They're really what systems analysts call the sharp end. And in the end, nothing happens in healthcare except pretty much through microsystems. Now, I'm not talking here about all the ways that people's health is affected through their behavior or through environmental influence, or we're talking here about the delivery system, not about all the influences on health. Now, macrosystems are surrounding, and they're sort of the sea in which microsystems exist and float. They are often invisible to people at the sharp end. When you're busy providing care in an emergency department or in a physician's office or a nurse's clinic or in an operating room, you're very focused on the work that you have to do. You're not necessarily aware of the extent to which what you do day in and day out is influenced by forces that exist in the outer world. But those forces are very powerful. They include things like regulations, governmental regulations, the way people are paid, the accrediting organizations that accredit hospitals, accredit training programs, that provide degrees for clinicians, recognize them as competent to perform certain services. And they include the way big or even modest-sized health systems are organized and governed. What's the management like? What are the priorities of management? What are the values of management? Do they value safety or do they not value safety? Do they value information and the free flow of information or don't they? These are all macrosystem influences on the day-to-day work of people who deliver care and on the day-to-day care that people get. The systems analysts call these influences the blunt end. I'm not sure where that came from, but that's what it's commonly termed. And in fact, people who study large systems and their behavior tend to think that the blunt end is much more powerful than the sharp end. But that is not the common wisdom among clinicians. Clinicians kind of feel like all those people out there are kind of waving their hands and running around. They're the suits. They're the suits, and they do stuff that's really not relevant. If they just knew what we did every day, they would realize how irrelevant they are. But I'm going to make the case that they are, in fact, or that the macro systems are the critical influence on that we need to be aware of as we go forward to try to improve health system performance. So we actually know a lot about microsystems. The reason we know a lot about microsystems, and I say this as a academic, reformed academic, is that microsystems come in large numbers. There are lots of clinics, there are lots of doctors' offices, there are lots of operating rooms, there are lots of hospitals, there are lots of doctors, there are lots of nurses. If you want to do an empirical paper and publish it in an academic journal, you are much better off trying to study microsystems than macrosystems, because you can demonstrate that if you pay physicians differently, or if you organize them differently, or if you give them a computer to put on their desk, you can study and measure with a sufficient sample size the effects of that very defined intervention. And the reductionist scientific method always tries to isolate the intervention and control everything else. And it's much easier to do that at the microsystem level than it is at the macrosystem level. So we published, we collectively, the academic enterprise, publishes a lot more about microsystems and how to make them work better than it does about macrosystems. And the studies are cleaner, and they pass peer review, and so they get published. Some of the things we know that work are reminder systems. So 25 or 30 years ago, I published with a colleague a review article about the effect of reminder systems on physician compliance with guidelines and quality of care. And lo and behold, this will come as a shock to anyone who has a significant other, or certainly if anyone has children. When you remind people to do things, they do them, or more likely they do them. Not always, but they're more likely to do them. My wife reminding me has a great effect on my compliance with her wishes. And we know that. And yet, you know what? It happens in the delivery of health care. It doesn't really matter what the reminder is. It could be a computer, but it could also be just a yellow sticky on the desk saying, this patient has diabetes. Please remember to refer her to a podiatrist. You're more likely to do that if someone sends you a yellow sticky with that reminder on it. The same has been proven to be true for computerized decision support, CDS so-called, up there in the right-hand corner. CPOE, computerized provider order entry. These are computerized ways of affecting decisions in real time. Some of them can be as simple as reminders. Some of them can be informational. Some of them can be analytic and predictive algorithms. They come in varying packages, but there have been a bunch of reviews of literature that show that if you take one group of providers and give them computerized decision support and another group and don't give them, and you have a sufficient sample to see an effect size on the condition you're studying, that yes, indeed, they do affect compliance with guidelines. They do affect process of care. They do affect outcomes of care. So another example of something that works. We believe care coordination works. There's a less of an empirical basis for that. The Toyota production system is a generic approach that goes more colloquially here under the rubric of continuous quality improvement. But continuous quality improvement on steroids is the Toyota production system. It comes from Toyota, the car producer. Toyota pioneered it in Japan, but there are a number of places in the United States, Virginia Mason Health System on the West Coast, the Denver Health System, other places that adopt it and show pretty dramatic improvements in the efficiency of care using continuous quality improvement and the Toyota production system. So we can, and we can go on. There's another marvelous set of interventions for frail elders called the PACE system, which I won't go into in detail, but it's a relatively proven, well-studied way to improve the quality of care, reduce the cost of care for frail elders. Community health centers long ago demonstrated that they are more effective at delivering care to low-income populations than individual clinicians practicing in small groups or a solo practice. We know a lot about how to improve care. But we don't use what we know. It just stays on the shelf. Sometimes it goes a certain way and then it stops. And I've spent many hours sitting around tables like this with colleagues, scratching our heads about why we can't get people to do what we know works in the health system. So, my hypothesis is, and I think not just my hypothesis, that we have failed to create macrosystems that support the adoption and use on a large scale basis of the information that we've learned about how to improve microsystems. Another way of saying that is that to get to fundamental delivery system reform, we need to make it easier to do the right thing. If you want people to do the right thing, you can't expect them to do it if it's a struggle to do it. If you make it costly, difficult, if they have to defy the rules of the environment in which they live in, if they have to sacrifice income, they will be less likely to do it. Another way to think about it is we can't expect performance to improve in a health system if everyone has to be a hero or an altruist to make the system work better. Now, one of the little-known facts about the Affordable Care Act is that it's the most important macrosystem reform intervention in the history of the US health system. You wouldn't know it. All of us know about the failed websites. All of us know about the president's so-called lie to the 5% of Americans who, in fact, are at some risk of losing their insurance. But no one talks about the remarkable set of tools that are contained in the Affordable Care Act for changing the blunt end, the rules of the game in which clinicians work in the United States. The way I like to symbolize this is that we have a toolbox for change, and it's now full. It was filled to the brim by the Affordable Care Act. It has new methods of payment to pay for value, both for doctors and hospitals. It rewards people for reducing hospital-acquired or healthcare-acquired infections. It rewards hospitals for not admitting Medicare patients within 30 to 60 days after their discharge, or it penalizes them for doing it. It incents Medicare Advantage, which are managed care plans, to provide higher quality of care. It pays them more if they provide higher quality of care. It promotes the use of medical homes. It pays primary care physicians more so that they are more likely so that young people are more likely to go into primary care. There are just a lot of things it does, and it creates new powers for government at many levels to change payment systems and make care work better. Matter of fact, the toolbox is so full that healthcare policymakers are a little bit like children looking at what's under the Christmas tree. They don't know quite which package to open first. Should I work on hospital-acquired infections? Maybe that's what I should work on. No, maybe I'll work on readmissions. Well, do I want to create a bundled payment opportunity? Do I want to be an accountable care organization? I have to get ready for the value-based payment system that is going to be coming along in a few years. All these things are impinging on providers of care at the same time. And so there is a danger of kind of Brownian motion and lack of direction, lack of unity. So that's one reason why the Commonwealth Fund, through a commission that is now sunsetted but had made this report about a year ago, said, here are some synergistic policies. You put them together. This is what you can do as a package. and you could get substantial savings if you were to do these things together. I'm not going to spend a lot of time talking about them, but you can all, if you like, find this report on our website. But I would also caution you that we're not the only ones in this game. There have been a whole series of reports making the same case, and the interesting thing is that some of these are bipartisan. So the Bipartisan Policy Center, which is up there on the upper left, is headed by Republicans, or shares leadership with Republicans and Democrats. The Simpson-Bowles Commission, which was about deficit reduction, is a bipartisan group, and that has also adopted very similar recommendations. And there's a lot of consensus on a whole set of things that include provider payment reform, delivery system reform, Medicare reform, consumer and patient engagement, enhancing the performance of healthcare markets, simplifying healthcare markets. There is a emerging consensus on how to make the system perform better, how to make macrosystems encourage better microsystem performance. Now, I don't think that we know why, but the fact is that healthcare cost increases are moderating. Matter of fact, they are at a historic low, historic in the sense that they are lower than they have been since Medicare was enacted in 1965. The rate, that is, the rate of year-on-year increase has gone from an average of about 3% in excess of gross domestic product to about 1% in excess of gross domestic product. And that is a pretty substantial change. The troubling thing is no one understands why. I mean, there are theories. A very well-known economist named Victor Fuchs wrote an article in the New England Journal in which he basically said it's all the recession. Every recession causes a reduction in the rate of increasing healthcare costs until the economy recovers, and then costs start going up again. And then my colleague David Cutler, an economist at Harvard, says, well, not so fast. The models that factor GDP growth into predicting healthcare costs don't fully explain this dramatic drop. Maybe recession's contributing some of it, but it's not explaining all of it. Maybe some of it's the result of the changes that the Affordable Care Act has caused, or that began to be in place before the Affordable Care Act memorialized them and expanded on them. It's a debate that's ongoing right now. It's generally good news. More good news is that some of the changes that are recommended by all the groups that I mentioned are in fact under the influence of the Affordable Care Act beginning to take shape. So integrated care is spreading if you believe that so-called accountable care organizations are integrated. I think that's a stretch, but they are the promise, they hold the promise of creating integration. Accountable care organizations are a creature of the Affordable Care Act, and their most salient property is that they incorporate some level of risk bearing on the part of providers. They offer the opportunity to share savings with the Medicare program if a provider manages to manage care in a way that reduces the rate of increase in costs for Medicare patients. There are some private sector ACOs, there are some Medicaid ACOs. The name and the program, though, took shape under the Affordable Care Act. And there are now 400 some of these these accountable care organizations. A few more than people expected. We can talk about why it's more than people expected, but nevertheless, they suggest some change at the grassroots in how care is being delivered. Some perhaps seeds of fundamental delivery system reform. Now, even if we are doing well, even if the moderation in healthcare costs were to persist, we would not have solved our cost problem. And one way to illustrate this problem is with the following infographic. So what this shows you is the GDP for the leading economies of the world. It starts on the upper left with the United States. We have far and away the largest GDP in the world, about 30% more than China. Of course, China is growing very fast. After that comes Japan at 4.4 trillion, then Germany. Oh, and then what's that? Thing with the stethoscope on it. That's the US healthcare system. The US healthcare system has the 5th largest GDP in the world. If you put the US healthcare system on an island and floated it out into the North Atlantic, it would have an economy that nearly the size of Germany and larger than France. That's how big our healthcare enterprise has become. Now, another thing to keep in mind is that one of the reasons it's so big is not because we're spending money wisely. We have enormous sources of waste that people generally agree exist. Probably the most annoying is that dark blue band in the middle, which is administrative complexity. Our cross-national surveys show that far and away, US consumers spend more time dealing with insurance companies and more time sorting through denied claims and more time trying to figure out how to get health care than any other country in the world. And that's because where I spent most of my professional career at Mass General Hospital in Boston, they had floors and floors of clerks whose job it was to bill and get paid. And down the street at Blue Cross Blue Shield, there were floors and floors of clerks whose job it was not to pay the Mass General. So it would have been, if we could have just gone out onto Boston Common and had it out, it probably wouldn't. It would have been a lot more efficient. Once and for all, we would have. But that's not the way the system works, of course. And there are other issues. Fraud and abuse are major issues. And failures of care delivery, overtreatment. Certainly, anyone who works in healthcare sees overtreatment every day. Another way of thinking about why we can't be content with current rates of growth in healthcare is to think about what economists call opportunity costs. So anytime you spend $1 on one thing, you're giving up spending $1 on something else. That's the cost of the lost opportunity to spend something on something else. If the US healthcare system over the last 20 years, 30 years, had grown at the same rate as the Swiss healthcare system, the Swiss healthcare system is not a bad system. Swiss are pretty happy with their system, according to our cross-national data. And no one is fleeing Switzerland in search of a better healthcare system. If our system had grown at that rate, we would have saved $15.5 trillion over 30 years. Now, what could you do with $15.5 trillion? Well, you could transform our $11.6 trillion federal debt into a $3.9 trillion surplus. End of the debate about the deficit. You could send 175 million students to 4-year college free. That would, as someone who put 2 children through school, both undergraduate and medical school, that sounds very good to me. You could have increased spending on public health by 20,000%, and you could buy everyone in the world 4 iPads. Now, we do have an opportunity. We've wasted a lot of money, $15.5 trillion, pretty much wasted. That's an incredible, incredible opportunity cost over the last 30 years. We have the opportunity going forward to rectify that. That's the stakes that we face in trying to create a high-performing health system. Now, if we were to preserve the current rate of growth for US healthcare spending, national health expenditures per capita, at the current rate that we've been observing over the last couple of years, this historically low rate, we could save $770 billion in the public sector alone. So that's the federal government. $770 billion. That's plenty to purchase everything that's being bought under the Affordable Care Act. And it would do an enormous amount to reduce our federal deficit. So there's a real opportunity going forward to reap savings if we get purchase on the rate of increase. So is this the dawn of a new day? I don't think the verdict is in, but I do think there's just no way we can abandon or stop pushing as hard as possible on the macro system changes that are available to us through the Affordable Care Act. There's an enormous amount of work being done with those macro system opportunities, the tools in the toolbox. Gets very little attention, but it is a very important part of the current environment. And states, I should hasten to say, are doing their own work through Medicaid reforms at the local level. Now, the answer is partially up to all of us, because if none of us is aware of or studies or calls attention to the opportunities built into the other features of public law, then they're much less likely to get the support and the implementation that they actually need. Now, a brief update on IT. I think of information technology as a macro system change. It has microsystem manifestations, but the policies that are causing the effects that I'm going to describe here are the result of a macro system change. The change in the way policy incentivizes providers of care to manage information. That's what's been going on over the last couple of years. So when I took over as National Coordinator for Health Information Technology, about 17% of US physicians had a basic electronic health record and about 8% of hospitals. And that meant that we were pretty much managing health information in the United States the way Hippocrates did 2,400 years ago. So it was paper and pencil instead of chiseling it on stone or writing it on papyrus, but I don't consider that a big advance. The basic idea was you had a physical manifestation of information, and you put that on a shelf, and you retrieved it physically when you needed to see it. That was the way information was managed in almost exclusively in 2008, not so long ago. So in response to the recognition that not much was changing on that score, the Congress put in place a piece of legislation, not part of the Affordable Care Act, part of the so-called stimulus bill. And that legislation provided clinicians with incentives and hospitals with incentives to adopt and use, meaningfully use, so-called, certified electronic health records. And my job was to implement this. And the legislation said, they created the office, said my job was to create a nationwide, interoperable, private and secure electronic health information system. And the president proceeded to announce that every American would have an electronic health record by 2014. But there was some money behind it. Every clinician, every doctor or nurse, anyone who billed Medicare and Medicaid was eligible for somewhere between $44,000 and $64,000 in extra payments over a 5-year period. And hospitals could get a bonus of $2 million plus an annual increase in their per DRG payments, which could come to quite a lot of money for a big hospital. And it was estimated the expenditures to implement this would be somewhere between $9 and $27 billion over a 5-year period or a 10-year period. What's happened with that? Meaningful use, which is the criterion for payment. So you get paid if you're a doctor or a nurse or a hospital, you get paid that extra money if you can if you attest to or prove that you're a meaningful user of an electronic health record, certified electronic health record. Well, as of July of this year, or August, about half, it's now close to 60% of all the eligible individual clinicians have received payment under the Meaningful Use program as meaningful users of electronic health records, and 60% of hospitals have. What that means is that there's been a very rapid change in the way information is managed over a very short period of time. This is what the rate of use by national surveys of basic electronic and health record, which is the lower line here, looks like. And there's been about a quadrupling of the proportion of office-based physicians in the United States who have an electronic health record, and including a basic electronic health record. I can talk about what that constitutes in detail if you're interested. The change in hospitals has been even more dramatic. It's gone from it's been about a quintupling from about 9% in 2008 to about 44% in 2012. These kinds of changes are not common in any social system, in any economic system. I guess they're common with the adoption of new consumer-friendly technologies, perhaps like tablets. But they're not common, and they're certainly not common in healthcare. We've begun to create an infrastructure for health information exchange, which is the ability to move information from one electronic record to another. Still pretty primitive, but it's ongoing. And so I guess the point I wanted to make for you is that it is possible to make macrosystems change and to thereby affect the behavior of microsystems. For every clinician who has gotten a meaningful use payment, lives have changed, work has changed, often painfully, as I will readily admit. Now, I should also say that I used an electronic health record before I went to the Office of the National Coordinator. So I am not without acquaintance with the challenges associated with them. Most surveys show that despite the pain and suffering that is associated with the adoption of these technologies, that 80% of the physicians who use them this year would not go back to paper. So as hard as they found it, now that they're over the hump, they prefer to be where they are. Now there's still 20% who would go back. But that's not a bad, from my personal standpoint, that's not a bad ratio. And we'll see if anyone actually does it. I would be surprised if they do. So we have, I guess, a half an hour for questions. And I'd be glad to answer any questions that are not about ethics. Don't consider myself an expert in ethics. I'm joking. Yes?
I'm Nancy Ray, I'm on the nursing faculty, so I'm going to ask the nursing question. And I'm glad that you did mention nurses in both microsystems and macrosystems.
I've been trained. I'm trainable.
So where do you think we are with some of the IOM recommendations about? Because it seems to me that's one of the easy places to look for improving cost and efficiency, and in terms of involving more nurses living up to their scope of practice. The IOM report on the future of nursing, which came out last year, for some of you who don't know about this and don't live in my world, suggested that the shortage of primary care providers could be helped along tremendously if advanced practice nurses could be allowed to practice at their full scope of practice. And lots of commentary in the New England Journal around this, and in ways that were seen as helpful rather than competitive in terms of taking, as you mentioned, some taking away, some parts of the medical community view this as kind of a competition that would be taking away from the incomes of medical practices to have nurse practitioners. And it just seems like we're at the point now, as you showed so dramatically, that these kinds of obvious potential areas for improvement could really help make that difference. And I just wonder what you think about that report.
So I actually wrote the editorial in the New England Journal. It's all right. I never remember who writes anything. But sometimes I remember what I've written.
In response to Jack's,
There was a survey published that surveyed primary care physicians and advanced practice nurses and compared their perceptions of each other and of their work.
that just came out a little while.
That was earlier this year, yeah. Basically, it showed that they were from Mars and Venus. I mean, that they did not inhabit the same universe. They could work side by side and have completely different perceptions of the work they do. So I think that we state this in much too stark terms as a choice. I trained as a primary care internist in a team with a nurse practitioner. And this is a long time ago, but I was part of a forward-looking program. This is in the 70s. All my career, I worked with nurse practitioners. And I liked working with them, and they were happy to have me helping them at times with their patients. And that, to me, is where we should be going, not toward isolated advanced practice nursing, isolated physician primary care, but teams that take advantage of complementary skills. So that, in fact, is what I think the resolution of this potential or apparent conflict ought to be, which is the development of interdisciplinary teams where advanced practice nurses do what they are proven by empirical studies to do as well or better and cheaper, and physicians do what they are proven to do. If we didn't need physicians, we could stop training them and we could just train nurses. If we didn't need nurses, we could just stop training them. No one is advocating either of those. There's a general acknowledgement that the training is different and the difference in training add value to each profession. What we haven't figured out is how to get them to work together in a collegial, equal relationship. And that seems to me where we ought to be going. Yeah.
Thank you. I really appreciated this. I'm an internist, endocrinologist, and I have the privilege of being on the governing board of an ACO, huge ACO. And this is, we're learning as we're going along. I mean, and HHS is in the same boat. I mean, they're not sure how it's going to work. So, like, you've done something for 9 months, and they, no, we're not going to do it that way anymore, and you go back. So it's very, very exciting, and I think that is the kind of setting where we're going to see the bridging, because you need the care coordination, you need the case management people, you need also the social services. I mean, the whole spectrum of what goes into dealing with patients. And what I'm excited about is that for the first time ever, because most of our hospitals are basically community hospitals, there are 5 hospitals involved, that there was always like this tension between the hospital administration and the hospital authority and the medical staff, the volunteer medical staff. And because they need each other now, this is a very different conversation we have. And the fun thing is that I'm there not with my credentials of having been a Joint Commission board member for 14 years, but I'm a patient, because they needed a patient. And since I knew the game, they just said, would you be okay with being the patient? I said, fine, I'd love it, because I'm in on it, and I don't have to, you know, chair any committees and stuff like that, so anyhow, I'm excited
Are
about
you a
it.
typical patient? I was going to say you got a ringer. Yes.
You know, I work for the Veterans Health Administration, and it's the biggest integrated healthcare system in the country. By many of the things that you talked about, every microsystem we've implemented or led some of those things. Where is that in the debate, or where are the lessons learned from?
Well, the VA operates according to different rules. It's a huge prepaid, potentially integrated healthcare organization. So just for those of you who are sitting around who may not be familiar with the VA, it's of course the system that was created by the federal government to care for veterans. If you have certain qualifications, you can get free care in the VA system. There are VAs, Veterans Administration facilities all over the United States. They're in New York, they're in Boston, they're in virtually every city. I don't know how many of them, how many VISNs there are.
50 hospitals, 1,500 facilities.
Right. And every year the Congress, shouldn't say every year the Congress appropriates a budget, because most years it doesn't appropriate a budget, but every year it does provide authority to the VA to spend money. The VA can't exceed that amount. That's not true of the rest of the healthcare system. The sky's the limit. You know, you get paid on a fee-for-service basis, and if you had more services and higher prices, you get paid more. So for years and years, the VA was viewed as a kind of, what's the right word? A dark corner of the US healthcare system. And when I was much younger, people would say, well, if you like the VA, then you'll like national health care. And that was sort of like end of argument, because you know the VA was viewed as a place where people went to be housed, warehoused, and to die. About 20 years ago, 15 years ago, that perception totally flipped. And the VA became, by objective measures, one of the best performing parts of the US health system. And the reason for that change was that I think because the leadership and the support systems changed. One of the critical elements was an electronic health record, which many VA people now criticize and probably is outdated. But it was, at its time, when created, a unique and powerful influence. The other thing is that there was an enormous effort to create integration between inpatient and outpatient care. You could explain it much better than I can, but systems changed. And as a result of changing systems, performance within the clinics and the operating rooms and on the floors of the VA got better. And it would never have happened unless the systems changed. So the VA is a case in point of macrosystem effect on microsystem performance. No one should be confused about where care is provided. It is provided by clinicians in direct contact with patients. It happens at the sharp end. But the potential of clinicians and the potential of patients to get and receive good care is enormously influenced by the macrosystems in which they work. So what happened was that the VA unleashed the potential for better care. And that's where I see it. Now, the problem with the VA is that it is unique in the US ecosystem. No one is proposing that any large part of the US healthcare system be nationalized. Nor can you be sure that if the VA were 100 times its current size, that it would be as good as it is. Because there are points at which systems become too large to manage. Nor is there any evidence anywhere in the world that anyone has effectively run a nationalized health system of the size that ours would have to be in order to cover our population. So, from Alaska to Key West, out to Hawaii, and everything in between, 330 million people, doesn't exist anywhere. Well, I should say it probably exists in the Soviet Union, or did. But there's no system that anyone would want to emulate. So I think the VA is great as a case study. I think it proves it's sort of proof of concept. But I think it's a unique part of our healthcare system that has some applicability. I think there are lessons and models that can be learned from it, that can be transferred. But whether the system as a whole creates a model, I'm not convinced.
Is it so politically unpalatable to even mention learning good things from a federal healthcare system that that's why it seems to me that it's absent from the dialogue?
I don't think it's absent at all. I got asked constantly about the VA information system and why we weren't just forcing everyone to adopt it. Or people would say, just make it free, the software. Well, it is available free and no one uses it. That's a topic unto itself. But there are systems within the VA that have been replicated. So the VA created a national surgical quality measurement program that is now widely used and endorsed by the American College of Surgeons and widely used throughout the U.S. So it's not that nothing gets transferred, but the transferability is limited because of the unique macrosystems that exist in the VA. They don't exist elsewhere, so the microsystems wouldn't necessarily be supported elsewhere.
Yes.
A few things. I was struck with a terrific talk. Thank you so much. I was struck when you were showing the states with better and worse healthcare efficiency, how much you've lined up with sort of red states and blue states. I wasn't sure.
You said that, I didn't.
Okay. I was curious which came first, chicken or the egg. The other thing, some people have over the years talked about sort of the practice of defensive medicine and doctors sort of being afraid to be sued, and that's why they end up with lots of unnecessary tests. I mean, is there room as a lever for reform of that, or you don't see it as much playing with?
So one of the things that our commission at the Commonwealth Fund on confronting costs recommended was reform of the tort system. The tort system is a terrible system. I've been sued more than once as a primary care physician. I think and I have many colleagues who studied this at the School of Public Health and elsewhere, Harvard School of Public Health. And it misses many injuries and penalizes clinicians who don't commit errors. And so it's just, by every standard, inefficient. And 30 or 40% of the money goes to lawyers. So it's clear that Sweden, New Zealand, other countries have come up with no-fault systems or administrative compensation systems that would be far more efficient. They would not be consonant with American culture. The opportunity that you have in the U.S. to get compensated in the kind of wild west of our court system is, to many people, a very important right. The right to sue if you're aggrieved. And to limit that is not easy. Now, it's partly politically difficult because of the trial lawyers as a lobby. But there are also, I think, would come up, and I don't know if there are any lawyers in the room or constitutional lawyers, I don't know how much you can limit the right to sue without transgressing on important constitutional rights. So, I just don't know. But I do think it is an important thing to do. I don't think it'll save vast amounts of money, but I think it would be so welcomed by clinicians that the mood around discussions of all kinds of other things would change. The psychological effect on the willingness of clinicians to be part of the solution would be enormous.
Hi, I'm a student at the Bioethics program here. And as you, with the map that you showed with the lowest performing states, many of those also, the governors also rejected the Medicaid expansion in those states. What kind of policy argument could you use to kind of persuade those governors to take on the expansion?
Well, let's put ethics aside. There's first of all a huge economic argument. These Medicaid supports constitute for all the states that have expanded Medicaid, have not expanded Medicaid, so the 30-some states that have refused to date or have not decided. There's about $500 billion over 10 years in federal funds on the table that these states have said they will not take. And that's a huge amount of money for many of these states. Ohio, which recently tipped into the expansion group, will get 50-some billion dollars over 10 years as a result of doing that. Now, that 50 billion has a multiplier effect. So when you employ somebody in healthcare, which is one of the things that happens when you expand the amount that you spend on healthcare, that employed person buys a home, buys furniture, buys a car, buys groceries, and you end up employing lots of other people. Those people then pay taxes at the state and local and the federal level, and they stimulate economic activity. So I think that the actual cost probably exceeds the $500+ billion. So the economic argument, in my view, is likely to be the one that's most persuasive over time. Most of the states that have refused to expand Medicaid, many of them, were also states that were very slow to adopt it when it was first passed in 1965. So people forget that when Medicaid was passed in 1965, all 50 states didn't rush to adopt it. It was 1982 before the last state, Arizona, decided to participate. And it took about 10 years before most states joined. So this reluctance to do a big change in Medicaid, and about half of the states that have been slow to expand were also late adopters in 1965. I'm reasonably confident that after a couple of gubernatorial elections, after the controversy around the Obamacare, Affordable Care Act simmers down, as the hospitals continue to push on their legislators to let the money in, and as the case for adoption or expansion of Medicaid becomes clearer, and they can make the argument that even if the federal government doesn't fully honor the promise over the next 10 years to continue to pay 90% of the costs, that it would still be a good deal for the state because of the state revenues, the income tax and the local taxes that would be paid. I'm pretty confident that this part of the Affordable Care Act, if it's not repealed, will be fully implemented. There may be 5 or 6 states, especially some of the states that are poor performing, that will still not adopt, but I think we'll get to 40 or 45 over the next 3 to 5 years. That would be a big change in the cause a big change in the level of uninsurance in the United States. Be about 9 million people, or 7 to 9 million people who now are uninsured who would then have insurance.
There was the article in Time magazine a few months ago that got a lot of attention about the disconnect between what hospitals charge and then what insurance companies pay and what people pay who are paying out of pocket, and the general lack of transparency around the whole process of what actually makes up healthcare costs. So I was just wondering if you could talk a little bit about that, especially related to the Affordable Care Act.
So I can talk about it. I'm not sure I'd have to think about how it relates to the Affordable Care Act, but So we have a really bizarre pricing system in the United States. Hospitals maintain two books, actually probably hundreds of books. But one book is what they say they charge, what the nominal charge is. And the other set of books is what they have negotiated as a price with insurance companies. And then there's another book, which is what Medicare and Medicaid have said they will pay. There's no negotiating with Medicare and Medicaid. They just set a price. So there's what hospitals would like to collect, what they are able to collect from private insurers, and what they're able to collect from Medicare and Medicaid. Now, what Stephen Brill in that article was talking about was the first book, which is what hospitals, I forget the name for the, but there's a word, charge master. It's what their charge master has. So this is what the computer says, aspirin or a anesthesia or the use of an operating room or an IV infusion, what all those things cost. And those fees are astronomical, astronomical. And they're astronomical because if you start really high, then when you negotiate with the private insurance company, you can say, oh, you're forcing me to cut my fee by 99%, and that's in fact what happens. You know, they do force 50, 70, 80% reductions in the fees, and that's what they come to agreement around. So there's a kind of wink-wink about this. It turns out, though, that by the time you actually whittle the fees down, they still end up being much higher than the fees that are paid in almost any other country. So an appendectomy in the United States costs 4, 5, 6 times what it would cost in the United Kingdom or France. That's paid amounts, not charged amounts. But if you paid what the charges were, it would be 100 times what it costs anywhere else. So there's this kind of shadow boxing that goes on behind the scenes. And that's why it seems so crazy and so counterintuitive to most people who observe this. Now, prices are still high even after they're negotiated down. Where it really becomes painful is when people are self-insured, i.e. uninsured, because there is no negotiation beforehand about what they're going to be charged. So they get sent a bill for the full charge master. You know, the $40 aspirin and the $500 bag of saline and all those crazy things that bear no relationship to the actual cost of the care provided. And then they end up negotiating with the hospital or the clinic to make the care affordable and end up sometimes going bankrupt. So that's the real, I mean, ethical rub of this, that there are some people who are truly victimized and they're the least able to defend themselves. Yeah?
So will affordable care impact the system in some?
The pricing?
Yeah.
So there's no price regulation in the Affordable Care Act. As a matter of fact, there's only one place in the entire United States where prices are regulated. Let me change that. There is only one place in the United States where private sector prices are regulated, and that's the state of Maryland. Medicare regulates prices by kind of saying the price will be X. It's actually not a regulated price, it's something called an administered price. It's set by administrative directive. There's no formal regulatory process. It's just kind of Medicare says, you know, this is how we're going to determine prices, and it's going to be this and this and this and this, and take it or leave it. So we don't regulate prices, and the Affordable Care Act doesn't create any authority to regulate prices, certainly not in the private sector. What it does do through the marketplaces is create the potential for competition between insurance companies on premiums for defined products that are transparently advertised and transparently created. So in the marketplace, you can buy policies in 4 metal tiers: bronze, silver, gold, or platinum. Those tiers are defined by the proportion of the actuarial value of the expected cost of care that are covered. So 60, 70, 80, 90%. And there is a kind of crude parity in that, and that parity enables people to make choices among insurance plans within a tier with some reasonable expectation that they're buying a similar product. In fact, there are differences, but at least you know that the expected value of the product is predictable. That competition, if it is allowed to take place, will put new pressure on the premiums of insurance companies, and that pressure will then be transmitted back in negotiations to providers. That's one element, very indirect element, in terms of price or cost control. There's almost nothing in the law that I recall that, for example, requires price transparency. So this is any requirement to publish what providers pay to insurance companies. And that has never been, that transparency has never occurred, or it's only occurred, I think it's occurred in one state, I think the state of Maine. But it has rarely occurred because insurance companies have argued that that negotiation is a proprietary activity, and that what they are able to negotiate with a doctor or a nurse or a hospital reflects their own, skill and technique and, what they offer and so they don't want anyone else to know what the price is. And actually, providers are pretty happy with that too, because if they can negotiate a better price, they don't want everyone to get that better price.
Actually, we've got to stop because we're out of time, but perhaps if you have a few minutes to hang around if people have other questions.
I actually have to, I've got a 7 o'clock train tomorrow to Washington, so I need to get back, have dinner, and go to bed.
All right,
but I'm gonna,
unfortunate to stop there, but clearly many issues, and maybe we'll have you back if that's all right. So
Sure.
please join me in thanking